conventional medicine has always recognized that late onset hypogonadism was true, meaning that as you get older, testosterone levels get lower. So if a 55, 60, 65-year-old man complains of this, they will check testosterone and they would have more inclination on giving him testosterone.
Right.
Your paper was amazing. The paper that you did that showed that adolescents and young adult males, that was the age range goes what, 15 to 39?
That's correct.
15 to 39, there's a 20% incidence of testosterone deficiency in that population.
Right.
This is crazy. I think that was the first paper that opened my eyes, because I kept saying, at one point in my practice, we said we're not going to treat anybody below 30. When I saw your paper, I'm like, no. Those 20-year-olds are suffering. We need to find a way to help them.
Right.
So tell me about this paper and what it did for you. When you wrote
So in practice, as a urologist and as a reproductive urologist, we started seeing a lot of young people with low testosterone. I was trained in school of thought that late onset hypogonadism, age onset hypogonadism is like cataracts. Men get it when they get older. It's just inevitable. It's just going to happen. So
I like that.
No, cataracts will not happen in young people, right? So then it was very hard for me to put hypogonadism and adolescents and young adults.
Right.
So we actually said, hey, let's see how prevalent this is and what's happening to the T levels in this population. Forget the older people. Let's look at it in this population between 15 to 39. And so we did a cross-sectional study of NHANES, which is basically a database of all basically adolescents, young adults, the entire US population. And they collect data every so few years. And we found that the level from 1999 till 2015 has basically declined from like 600s to about 450.
Wow.
Still in the normal range, but you have to understand the median in 18 to 39 was 450. That means 50% of the population between 18 to 39 has less than 450.
That's incredible.
And
How
so
much percentage again?
50%.
50%.
Have less than 450. And now here you are asking me about normal levels of testosterone. This is the population where they drive the numbers from. And so if the numbers keep going down in the population as a whole, of course the normal levels are going to go down. But what was also interesting is we also saw that the BMI in this population went up. Not very surprising. We in the last 15, 20 years, we've invented cell phones, right? We've invented video games. Right. We've basically invented just about everything that'll make human beings more sedentary. You don't have to go outside and play.
Right.
And I'm sure we all can relate to how kids spend their pastime these days to how we spent growing up, and it's very different. And so none of this is very surprising, right? If I tell you kids these days eat more and spend more sedentary lifestyle compared to what we did when we were growing up as kids, I think everybody will uniformly agree.
Of course.
And then we say, oh my gosh, their testosterone levels are lower than what we were. You have to say yes to that, because if your lifestyle has changed and your eating habits have changed and your dietary habits have changed, your testosterone levels have changed.
Yeah.
And here we are questioning, why are the testosterone levels going down?
Right.
Right. So,
but if you don't mind, one interesting thing you had on your paper, although you showed that the higher the BMI, the lower the testosterone. But I think you also showed that even when you corrected for the BMI or for the excess weight, you still had a decrease in testosterone in people with normal BMI.
That's correct.
So this is something for me that was important for me, because I don't want to blame the victim. So we have a lot of 20, 30-year-old guys who come to our office, are fit.
Right.
They exercise, they change their diet.
47% of our clients are under 40.
Right.
Yeah, so they do all of those things, but despite this, they still have low T. And this is where the interview we did with Dr. Anthony Jim, that book, Estrogeneration, the impact of estrogenics and the toxin chemicals that are around us. Yes, obesity is a big driver of testosterone deficiency.
Right.
But it's not the only driver.
Absolutely. I think that's probably just the tip of the iceberg.
Yeah.
I think we still don't understand why testosterone levels can be lower, and if it is low, why is it low only in a certain proportion of patients? Why is it not low in some others? I think it'll probably take the next generation of podcast. They may not be doing this next generation. They may
virtual reality.
I mean, the meeting like this would happen in the metaverse.
Yeah. Okay, you know about the metaverse, Doc? All right.
Hey, listen, Doc,
look at that. Metaverse.
Yeah, they'd be talking in the metaverse about how people like us were talking about low T back then.
Yeah.
Yes.
So something important I liked in that paper also, you showed that the second quarter, the second half of the measures that you showed, there was a more precipitous decline in the second half.
Right.
So showing that So I'm wondering now, so that I think you stopped in 2016.
Right.
I'd love to see what the numbers have done from 2016 to 2022.
Absolutely.
I'm sure they went even
Absolutely.
a steeper decline.
Absolutely.
Right?
What did we do during COVID? Lockdown. More quarantine. We need to be more sedentary. Cannot be going outside. You're going to get sick. So we forced the kids to be even more inside the house.
And even more technologically adapted.
These masks. One of the things that Anthony was talking about is the breathing through these masks and breathing the microplastics that are estrogenic and attached to the estrogen receptor. It's huge. So I bet that the numbers will be
lower.
So and we've become even more adapted to using more technology. Kind of like
and
what
leading
you're
more
saying,
sedentary lifestyle.
What you're saying, it sounds also to me that we're oversaturating our dopamine receptors, meaning we're constantly getting a hit of dopamine. There's no challenge to the human today because they can get anything they want online or order it, and there's no working for
instantaneous generation.
Instantaneous generation.
Exactly.
I love that.
A couple of other things I liked with that study. Again, so you're saying like about 50%, the median was 450 in those adolescent and young adult males. And in your paper, you said most of the symptoms come at about 400 range.
That's
so
correct.
Younger men don't need to have a testosterone of 300 to have symptoms. So at the 400 range, the symptoms were there. So again, and another thing you put in the paper, that the symptoms in younger men weren't mostly sexual. We always think that if somebody has low T, the first thing they have is decreased libido or erectile problems. In the younger generation, what you put in your paper was mostly decreased energy. Lack of energy. How many times do we hear that?
Oh my gosh.
Patients like, I don't have energy to do anything. Apathy, decreased motivation. And what we're seeing even as a society, on a societal level, we have a generation of young men with no energy, no motivation, decreased mood, that's growing up, and that is not getting the right help. We need to talk about this. We need to raise awareness because those patients are not being helped the right way. And most of the times, they're being told, because the symptoms of low energy, depressed mood, they're being told it's in their head. So the patient now he internalizes the
identifies with it.
I'm a loser, look at this, I can't do this. And a lot of times they put them on SSRIs. That's it. So again, for me, psychiatry has gone from, you use those powerful medications like SSRI, Paxil, Zoloft. There's a place for them when needed, but they're so easy. You're depressed, you don't have energy? Try this. Why don't we try testosterone? Again, that study that you were saying, again, I've reviewed and I did a talk about it. So it's on JAMA Psychiatry, 2019. They looked at all those randomized clinical studies, and they showed that patients, it was an endocrinology clinic, out of the patient, about 39% of patients who were in the clinic for low T were taking an SSRI. Another study showed about 52% of patients with low T had 1 or 2 psychiatric symptoms. That's crazy. And it showed that by replacing testosterone, you improve those symptoms by more than 50%. So again, let me give you the typical patient we see. 38 years old, gained some belly fat, is not himself, he feels tired, he has mild ED, doesn't feel great, goes to see his doctor, his A1C is 5.8, pre-diabetic, he has metabolic syndrome, testosterone is 325. And they tell him, it's in your head, go and exercise. That same patient comes to us, we look at everything. Again, I don't follow the guidelines, unfortunately. I will put patients on testosterone if they have the clinical syndromes and a lower number. I will do a therapeutic trial. And in 75 to 80% we measured of cases, we have a positive response.
So absolutely. I mean, and one of the actually largest Australian studies that came out, I think last year or the year before, was in Lancet, Diabetes and Endocrinology, where they looked at pre-diabetic men with low testosterone. And they gave one group of men just testosterone, and in the other group, no testosterone, like placebo. And they followed them out for 1 year. And they found that the conversions of pre-diabetes to diabetes was a lot lower in the men that received testosterone therapy.
And we see that all the time.
So the whole concept of pre-diabetes, I think is a sign of testosterone deficiency. And listen, I don't think you'd be wrong in giving a guy testosterone if he has symptoms and his total T is 325. Usually in those cases, just to protect us from quote insurance and legal issues, I get a free testosterone. And free testosterone usually is normal in a guy that is so classic like that. with prediabetes, having symptoms, and the total testosterone is 325. And the Endocrine Society guidelines thankfully say that if your total T or your free T is low, then you can give testosterone therapy. So that's one caveat that I use free T for in people who have testosterone levels that are in the quote normal range, but still have all the classic symptoms. So anybody between 300 to 400. So if I feel that they have symptoms, I usually get a free T.
So to let you know, we always check free T.
We always.
To get that right, even if he might be on the upper end, if the free T is low, you'll base it off the free T and the signs and symptoms.
And that's an important distinction, because we get a lot of people that, they get inadequate labs, right? And so they'll come with the total testosterone and be like, no, my testosterone's fine. Like, for example, when I did it, my total testosterone was 600, right? So anybody would be like, oh, your testosterone's fine, but my free testosterone was 5. Totally inadequate, right?
SHBG was like
and my SHBG was super high, right? So, and my symptoms were never sexual. Like I thankfully never had ED or any kind of libido issues. Mine was all mental. It was all mental fog. Like I just couldn't focus, couldn't get myself going. So it's very important, like Dr. Ramasamy said, to get a free testosterone checked, because that will be much more determining of whether you qualify for therapy.
Yeah.
So good. So Dr. Ramasamy,
yes.
Would you say testosterone deficiency, hypogonadism, low T is a true clinical syndrome?
Yes.
With symptoms that can be helped?
Yes.
Thank you. Thank you.
Amen to that.
And no age restriction.
Yeah, no, because what we haven't talked about is we're mostly talking about idiopathic hypogonadism, but we also have a lot of young kids with Kalman syndrome, Klinefelter syndrome, anorchidism, testis cancer, radiation to the testis, radiation to the brain from brain cancer. All of this is 2 to 3% of the whole population. But if you truly see urologists, and you must see some of this as a specialist, is wherein all of these patients actually need testosterone therapy. Yeah. Right?
I had my first Klinefelter syndrome.
There you go.
Which was amazing. That's a genetic disease that causes low T infertility. Right. So it's interesting. We don't see those patients much because they usually go to the urologist, right? So we tend to see more the ones that are kind of borderline that no other doctors really help.
Right.
So I think we've established this. I think the next subject I really want to go about now, we know this is a disease.
Right.
How safe is testosterone? So let's start first with testosterone in prostate cancer.
So